I guess you can tell who has the most experience between us, maybe.
I think with that, we're going to start with just some data analytics, correct?
That is correct. All right, today in the room, we are looking at the current attendees and what their current role, function, or department is within their healthcare organization. Just give it a second.
Oh.
There we go. And it looks like we have about 46% of ITen and Analytics here in the room today.
Perfect. So with that, hopefully we'll be able to help explain a little bit about how you actually operationalize all this data that we're getting. But first, I want to make a call out that next time we should probably have a best shoe contest, not best socks. So we should probably put that on the list for next year. But what we want to do today is share the post-hard journey with you. So we've got a lot of data. We want to show you how we've actually operationalized it. We've come to some of these conferences in the past, or we sit through other conferences, and a lot of people show their great outcomes, and you're just like, oh, that's awesome, but how did you actually do that? And so we want to be able to actually explain how we did a lot of this work. So hopefully that's what you get from this today.
So you guys are 90% analytic and 10% clinical. I'm 50% clinical. She's 50% analytic, but just to let you know. So yeah, it takes. This is why we have a polarity that I think has worked for us. You have the thinker that thinks things through, that takes his time and tries to get things right, and then you have
somebody that actually gets things done. We don't have time to sit and think all day. We actually have to get going because we don't have time for that.
And it's surprising she can do this without her phone because she doesn't know which way west is without her phone. So
may be true.
You know, sometimes the old retrovert, the old boomer, needs to explain things to the millennial. And even though I'm a technotard, sometimes I have things that are of value to her. Not very often, maybe.
But as you can imagine, there's probably a lot of Gen Xers in here, how frustrating it is to try to explain to an older person how to create a folder on their computer to save a file, and how completely irritating it is. Well, that's what I get to deal with every single day. So it's a good thing you have somebody all-knowing.
She loves every bit of it.
So today, our objectives really are to start with alignment. How did we align everybody into the direction we're going? And then how did we actually give them the vehicles to do that work? And then how do we integrate the two? And then how do we actually sustain that? So that's kind of what we're hoping you go away with today.
So our mission is to build a destination center for heart and vascular health in the region. And we need to do that. We thought we needed to do that. We needed leadership. We needed to develop a culture. And we needed the governance. The governance was so important to us.
And so with that, we don't see ourselves as just an institute that has hospitals and clinics like most people do. We like to dabble a little bit in research. We like to see ourselves as a node. So we want to actually partner with sister healthcare organizations that are like us. One of our biggest intrigue right now is venture capital, and how do we actually insert ourselves in that space and let them use the little incubator that we've created in our institute to grow products. And then obviously we've got to be able to sustain, so we need to have prevention and population health management.
So when this was taken to the MultiCare Health Board, so we're a subsidiary of MultiCare Health System. And so we're not owned by them, but we're a subsidiary of them. We're totally employed by them. But the commitment to the board was that we would move the needle on quality, we'd move the needle on engagement, we'd move the needle on recruiting, and we'd move the needle on economics.
But we can't just sit around and think about moving all those things. So we also want to prove ourselves in things. So we wanted to prove that we could scale this thing. It's cool if we can do it right here, but can we actually do it other places? And if we can do it, can we do it in other clinical domains? One of the other things we want to make sure that we're able to do is fee-for-service is going away at some point, maybe, who knows. We're told it's going away, so we want to remonetize our platform. We want to figure out ways to actually make money not in such a fee-for-service market. And then we have to ensure that it's sustainable once people like Needham decide to finally retire.
She begs me every day. So Brittany has something for you.
All right, on to the poll question number 1. Just a reminder, you can submit your answers in the HAS app, and this is session number 31. On a scale of 1 to 5, how would you rate the effectiveness of your organization's alignment? 1, not at all effective. 2, somewhat effective. 3, neutral. 4, moderately effective. 5, extremely effective. Or 6, unsure or not applicable. I'll give you just a moment to submit your responses.
First off, this must be a data summit because they give you so many options. 6 options is a lot. So moderately effective. That's kind of how we felt. Well, maybe we were worse than that, but yeah, moderately. So in order to do this, we first had to align things. So we gave doctors some governance and control, but with that, you also got to make sure you give doctors some lanes to work in and give them some millennials to work with. So we need to give them alignment, we need to give them vehicles, we need to give them tools, and we need to educate on those tools. So we'll kind of go through each of those 4 lanes as we go throughout our presentation.
So we started with 14 cardiologists, 5 cardiothoracic surgeons, and a couple of surgeons, and about 450 employees over 5 hospitals. Since then, we've expanded somewhat. We've got about 40-some cardiovascular physicians, 40-some advanced practitioners, and about 850 employees.
So since we're a lot of analysts in here, I don't want to belabor the governance, but this is how we're structured. We are, as Needham mentioned, a subsidiary of MultiCare. So we have our own physician-led board. There's 9 members of that board. 8 of them are physicians, and 6 of them are practicing, seeing patients every single day. So we really feel like practicing providers give us the best input of how we should be running our business. On the other side of the world, we were given all of the cath labs, operating rooms, cardiac rehabs, cardiovascular, anything in your cardiovascular service line rolls up through us, and then we're seen as a business unit. So we're seen of just like any of the other hospitals in our health system.
And as always, when you start something new, there are a few flaws that you have to clean up. So what we did to develop this, we wanted a culture of care that was physician-led, but that was patient-centric. And so we came together and put together a compact. And on the right are all the types of things that we want to do with each other. You know, we want to do between the physicians and the patients, the physicians and the staff, and the physicians among each other. You know, how do we treat each other every day? How do we become aligned and develop a culture that will really work together to give the best patient care? And if there are obstacles, if there are issues that come up, behavioral issues, for instance, or clinical issues, on the other side, on this side of the screen, you can see the clinical behavior model. And we take that first. When something comes up, we'll take that to the director for that service. If things continue, it goes to the CMO and the director with a progressive improvement plan, and then the next step would be that. But we monitor, all of that is done by ourselves. We do all our own hiring, our firing, all those things are done by us, by the physicians, by the institute, not by the system and things, unless it's for cause. But of course, a lot of times the physicians always say, well, you know, it wasn't me, you know, maybe it's not me, you know, maybe it's the rest of the herd that's gone insane,
So with that, once we got them aligned, we then had to give them actually something to do. We can't just have a bunch of doctors aligned with administrators and we all sit around and decide what we're going to do. So we put together horizontally integrated programs that are based around patients. So they're DRG-centered, they're disease states, coronary artery disease, heart failure, valvular, vascular, and prevention. So and arrhythmia. And so they all are centered around patients.
So it's a multidisciplinary approach. All of those COEs, except for vascular, which is kind of its own niche, but have both surgeons and cardiologists within those groups to give that multidisciplinary approach. And this is very purposeful that we want them working together. We want the different disciplines of cardiovascular care working together.
And so with that, they need some leaders. So we have a physician and an administrator who are completely responsible for that product line of business. So they do all of the P&L, the care coordination, the improvements. They're responsible for that.
Yeah. So we want these resources to be around the patient. We want all these resources, all these different types of care around that patient. And we need to, if there's no margin, there's no mission. So we need to be financially, we need to be good stewards of what we're doing as well, and good for the system. This is why they hired us. They hired us to give the best quality care, but also to be stewards of their resources and to help them make a margin so they can go on giving care to patients.
So with that, budget season always comes around, and you're given your budget, and you're told you have to hit this margin, or you got to get this expense, and all you do is this whack-a-mole of here's my supplies, here's my labor, what am I going to do? Now we have physicians that are at the table with us, so we're redesigning our care pathways. We're looking at the way we deliver care and optimizing our margin through redesigning those pathways. So we're not perfect, and we're the first to know we're not perfect. But with that, our COEs have begun to evolve over time. So they have their P&L statements. We're asking our physicians to write strategic plans. And I don't know how many of you have asked a physician to write a business plan or a strategic plan, but that was like pulling teeth. So we're evolving. We're learning how to do things. But these are the things that the COEs are responsible for, and they have the tools to do it now. And kind of like I just said, operational, economic, and clinical outcomes are what the COE needs to do, and we don't need to read through that, but the leadership is a physician and an administrator using their skill sets together.
So what we wanted to do was give a continuum of care, not just an episode of care to a patient at a time, but a continuum of care to that patient with cardiovascular disease throughout their lifestyle, really, throughout their life. I mean, and so they come to us from the hospital or from their home, and we try to surround them with the resources they need to get the best care. So one of the things we did when we started...
Well, on that note, we have more data analytics. Sorry,
Brittany, get ahead of myself.
He's a boomer.
All right, on to pull question number 2.
She's a millennial.
On a scale of 1 to 5, how would you rate your organization's effectiveness in using data and analytics to establish and monitor organizational goals and outcomes? 1, not at all effective. 2, somewhat effective. 3, neutral. 4, moderately effective. 5, extremely effective. Or 6, unsure or not applicable. We'll give it just a few moments.
Yeah, pretty neutral, or moderate. Good. All right, so what we needed to do first was, whoops, sorry. Still coming. What we needed to do first was find out where are we, and we needed help doing that, and that's actually when we started working with Health Catalyst, I think. No, it's earlier. Okay, well.
He's kind of a boomer, loses his memory.
I forget some things, you know. But at any rate, Health Catalyst came in and gave us a hand, and they gave us they interviewed 37 of our, the physicians and staff and administrative people and et cetera. And they determined that there were certain things that we certainly needed for improvement. There were opportunities we had. I love that word, opportunities. But at any rate, we needed better access to data. But the problem was there's lots of data out there. In fact, sometimes there's too much data. So we needed data that was friendly, and we wanted data that was physician-friendly. We wanted data that we could use, that when we're sitting down with that administrative physician DYAD, that they could work together and understand the data that they were given. And this would help them then with finance. We needed better cost data, and we struggled to get that. But now that we have that, I think we really have things rolling in the right direction. We needed that vision of where to execute, how to execute, prioritize what we needed to execute on first, because there's so many things. All of you know, every one of you in your place of work has so many different things that you'd love to be working on right now, but you really have to prioritize them. And so we get a lot of help from our friends at Health Catalyst helping us do that.
So the first way to do this is giving them the tools. So we learned what we needed to do, and then we need to give them the tools. And this is where our analytics partners loved us, because then they were able to go back to their supervisor and say, look, we're being effective, not just we feel like we've reduced readmission rates. But we're actually able to show that we're effective. And the way we've done that is we've aligned the administrators and the physicians' scorecards together. So this is a scorecard from our doctor, just one of our doctors. They all get individual scorecards every single month. And it looks exactly the same as an administrator scorecard would look. So when we go through, we look at their subspecialty. So who are they? Are they a CT surgeon? Are they a cardiologist? And how do we align them as a subspecialty? That's important because you need a team of providers. And then the next step is, okay, well, individually, if the subspecialty is performing 90% at something, and this individual is only performing 10% at that, then we're going to give that individual doctor the goal to work on that, whereas another doctor might get another goal because he's already at 100%. So we're able to customize everybody's goals to them. That then cascades down to what we call a center of excellence or a team goal. So all of our doctors choose which center of excellence they're going to sit on, and they are then compensated, just like administration is, based off of how they're performing in that center of excellence. And then at the highest level, all of our providers carry the same goals that Dr. Ward and I carry, those institute level goals. So it cascades and it aligns everybody to the same objective. So the cath lab manager is working on the same thing the interventional cardiologist is working on.
And that sometimes is not easy for it didn't take long, but it's not easy to tell somebody, yeah, you're 90% on your CG caps, you're doing great, but that's not one of your goals. Because they had another goal that you're only doing 15% of your cath cases radially. We need you to do that. So individual goals would be like that, and that took some give.
So one of the things we really wanted to focus on this year, last fall, we decided that we wanted to really make sure that our patients were on the correct care pathways and guidelines. And so each of the COEs chose a higher end procedure that they're working towards, so TAVRs, LVADs, CRTs, and they put together the clinical indicators for these procedures. And then we ran it against the entire EDW within the health system to figure out how many patients there are that are clinically indicated for a certain care pathway and how many are actually on that care pathway.
So let's take one of those care pathways. Let's take TAVR. So we developed an app to look at all our patients that have echocardiographic criteria to have an aortic valve replacement, either by TAVR or SAVR, so surgically or transcatheter. And we looked at this app and we found out that of the 600, we found 623 patients. And so then we looked at, well, who's taking care of these patients? 60% of them were taken care of by cardiologists, pulse cardiologists. But only 12% of those were being referred. And that's a very small amount, we thought. So we thought, how are we going to improve this? So we had our navigator, our TAVR navigator, look at this app, look at it weekly, put out reports monthly, go to the review the data, find out the patient, find out the cardiologist, go to the cardiologist or the primary care physician or internist, and see what, this patient meets the criteria, just kind of letting you know if you need a referral, I'm glad to help you, et cetera. And now we've gone from 12% to 60% referral rate for TAVR in the appropriate setting.
And so a lot of this work wasn't just how do we grow those volumes, but how do we make sure we're catching the patient before it becomes an emergent situation and it's actually a preventative situation. So as we talk about analytics and where do we get our ROI, how do we go back and prove to the system that this is successful, in that TAVR conversation, each one of those TAVRs generates about $20,000 of margin. So as we were going along, we were doing about 2 TAVRs a week. We now are doing 4 TAVRs, and we're trying to get the OR to allow us to do even more TAVRs. And so it goes to show that ROI can quickly be built if we just align the right data with the right providers. One of our next things was our hospital president said to us, well, if you guys are doing so great, then how can you guys explore how we can actually survive on a CMS margin? And that's a tough thing to do. I think every hospital system is trying to figure that out. So we said, all right, we'll put our COEs on that, and we'll work through that. So we gave them all their margin per encounter. And I have to apologize, this is all sample data, so when it says things double, then you're like, well, your math doesn't really add up. I promise it doubled, it's just the data's not saying it does. So the structural heart was our greatest improvement. So when we looked margin per encounter, structural heart came out as one of our greatest improvement areas. We then use our Catalyst app to look into that, to say, well, why did this actually occur? Or was it something that we were actually working on? For good news is we were actually working on this, so it's not just a fluke that it increased. So the things we were doing to work on this were we pulled up the variation by provider. We can go in and say, Dr. Smith, you are performing at X dollar amount more than Dr. Y, and here's why. It's because you're ordering more CTs than him. You're ordering more labs than him. Or, hey, you're keeping your patient 8 hours longer than he is. Is there a reason why we're doing that? And so through that, we've been able to double the margin in some of our DRGs of those higher end margin-generating activities.
So our clinical outcomes are very important to us, and one of our major clinical outcomes are called door to balloon time, and I know a lot of you are analytical, and door to balloon is basically how long does it take you to get a patient having a heart attack from the emergency room until you get them in the cath lab and open that vessel up. That's what we call the door to balloon time. And that's an important metric. That's a publicly reported metric in a registry at the state of Washington, and something that's looked at. So, how do we improve that? Well, it takes collaboration, and it took collaboration with EMS. It took collaboration with the emergency room. It took collaboration with the cath lab team and the nurses and everybody. But when you develop that collaboration and then break down that process step by step, okay, door to EKG, how long did that take? EKG to cath lab, how long did that take? Cath lab to ready to stick, how long did that take? Stick to balloon, how long did that take? EMS, when did we have the EKG from the EMS, if that's the case? And how do we get EMS to have the EKG? And the other thing we did is looked at things, how do we get our physicians involved? How do we make this so we actually became very transparent with this. We post by name the physicians' door to balloon times in the cath lab. And what their door-to-balloon times are for that month, and so they can all see it. We've had engagement of the teams because it's almost become a competition, a friendly competition, and a fun process. And so, Dr. Atri in the middle there did an 11-minute door-to-balloon time for us a while back, and we celebrated that with him at appropriate time in an appropriate bar.
So probably you guys have this problem where you're just like, oh my gosh, there's so much data, where do we even start? We've opened up the floodgate and there's no way for us to even decide where we're gonna go. So that's the same kind of conversation we were having, is there's so much data, what are we supposed to do with all of this data? And as we sat down with our analysts, we kind of, what are other companies doing? How are other people doing this? We didn't want to recreate something that was already there. And as we looked at other people's, it seemed like it was so just, you had to be a data analyst to be able to understand it. You had to put in pivot tables, you had to move things around, and I was able to keep up, but Needham was having a hard time keeping his eyes open. And so I was like, let's figure out how to do this differently. We need something to look more like Apple friendly for old people, rather than, the Samsung, we can do everything we want. So we told them we wanted something very quick, easy. So physicians were going to understand exactly what it meant to them. So all of our applications right now are built in a way where each one of our doctors can go in and they can click on their name and it'll show exactly how they're performing it, whatever application we have open. And that's been something that, our analysts just love us for, because it's not the easiest thing to pull off, but our doctors are aligned with what we're doing if we're able to do it that way.
So this is a little anecdote I want to tell you. When we started, Holly said, we need to take a patient and we need to take a lab and how long they stayed, and where the room and board and all this, and we'll paste it on the wall. So we pasted
that's the lean process.
We pasted like 60 things on the wall, and I looked at it, the old boomer, and said, isn't there a computer that can do this? And actually, that's when we started working with Health Catalyst. So.
Yeah. So with that, we have another poll question.
All right, poll question number 3. On a scale of 1 to 5, how would you rate your organization's effectiveness in using data and analytics to establish and monitor key performance indicators, such as productivity, labor management, patient satisfaction, panel size, etc.? 1, not at all effective. 2, somewhat effective. 3, neutral. 4, moderately effective. 5, extremely effective. And 6, unsure or not applicable. We'll just give it just a minute.
You're kind of a moderate crew.
Maybe we should ask you
Where are those
ice
high
cream
performers?
or something. Is it?
They're all in with Burton.
Okay, so the next thing we also wanted to do was how effective are we operationally? So we've given the doctors all of this data. They know how they're performing, but how are our operational leaders actually performing? And so one of the ways we did that was, I don't know if you guys have these issues, but cath lab and CVOR efficiencies are a huge issue for us. And so we were able to put onto a heat map to say, where are our biggest opportunities for cath lab utilization? So by looking at this, we can actually take it to our physician group and say, I know you're all asking for block time on Friday, but look, Friday we don't have any time for block time in this cath lab. How about Monday? Or let's pull up one of the ones on the top and say, hey, at this hospital we have time on Friday, so if you want to drive to that hospital and have your block time, then that's fantastic, but we don't have any more room here. So we talked a lot about the DYAD relationship. We are built off of dyads with Impulse. We don't think that administration can do it themselves, and we know doctors can't. So we have to partner the two together. But what's the difference is I'm sure you've sat in a lot of meetings where there's not a single doctor at the table, and we're making decisions that are impacting patients, we're making decisions that are impacting doctors, and we don't think that that's right. We think that physicians should be as equal, if not more, than the administrator in doing these things. So when we put the dyads together, I'll admit that the first 18 months were more of marriage counseling, of Needham and I sitting down with some. We had to write some divorce laws for some and put them with somebody else. But we now have dyads that are functioning. And so as we have these dyads that are functioning, we have to help them understand that, your physician is going to be very vulnerable because they're always looked at as the smartest guy in the room. And so when you walk in and you know more about the finances or the operations, you have to be empathetic to him that he's going to be vulnerable or she's going to be vulnerable in that nature. And so the other thing is we have to be very cognizant that they're being called everywhere. We're telling them we have access issues, but hey, why aren't you in this meeting with me today? And so we have to be cognizant of that's being done. And then we have to remember all the time, we don't want heavy-handed administrators. We don't want people saying, this is the way we're going to do it because it's going to save us $10 more, but what's best for the patient?
So at the same time, the physicians have to take care of their administrators. They have to partner with them. They have to teach and be a willing student. And they have to understand that these administrators are working very hard as well. They're spending nights, they're helping them save time, helping the physicians save time by developing a lot of this for them and then presenting it to them. And so it's really important that physicians understand that and work with them. And you don't have to be a physician to be at the top of your field. I mean, the administrators we work with, the administrative team that we work with, is really good, and we have developed them, I think, over the last few years, so that we really have a well-oiled team, I think. And physicians have to also be aware then that you don't do an end run around your administrator. That's just a no-no, and you don't allow triangulation with others.
So with that, we want to make sure they have a lot of education. We want to educate them together so that they know the same things. And we know that physicians hear things better from other physicians. So we've been very intentional about when we bring in people to do this education on a quarterly basis, that we're bringing in a physician. And so when we do that, we've done things like quality improvement, leadership, and finance are kind of our 3 pillars that we try to educate on. And then if we're having some kind of struggles within the institute, or we know that we want to push us somewhere, we'll bring in a physician that's going to help preemptively talk about that for us.
And so again, looking back at the COPE data, the registry for us, you can see on the left, before we started Pulse, we were, again, the same cardiology group, but before we started Pulse, really we weren't really, I'd say there's too much red there, let's just put it that way. And then if you look 3 years later, now we are mostly green, I think. That one red one at the top is only 0.4 off, and that's normal now. And we've improved our CG caps and our HG caps as well. One of the things we looked at again was that door to balloon time. And if you look at this slide, you'll see that the door to balloon times, if Deaconess is on the far right, they just came on board in 1919. This is 1918.
Did you say 1919?
Or,
We are in the 21st century
whatever,
now,
whatever. Thank you. West is that way. At any rate, now they are down to about 50 minutes, so they've improved significantly in the last few months. But if you look at Auburn, Good Sam, Tacoma General, the door to balloon times there, these are in minutes, are all significantly. So those, Tacoma General was first in the state, Good Sam was second in the state, and Auburn was, Good Sam was 8th in the state, and Auburn was 4th in the state out of 33 hospitals that do PCIs, and that includes Swedish, University of Washington, Providence, whatever. So we had the best times in the state, but more important than that, we were the safest in the state for treatment of myocardial infarction. So that's an important thing.
And a lot of that was based off of the best practices built in the COE. So how do we actually drive that outcome? We bypass the ED and we go make friends with the ED so they're comfortable with us bypassing them to get them to the lab in time.
And likewise with heart failure, as you can see here, if you look about the middle of the screen there, we went through our COE and we said we're really not improving our readmission rates. We need to, what are we going to do? How is the COE going to look at this? COE put together a team-based approach to go into the hospital, have people in the hospital every day, see those consults, make sure they're followed up in the clinic. And I think as you can see, there's certainly a trend in the right direction. Everybody has trouble with heart failure for sure. Sometimes it's difficult. 25% of our patients are homeless, 25% have drug addiction issues, so it's hard to move that needle sometimes. But with really focused care, I think it can be done.
And that was something we used our analytics partners heavily for, because as you see, it's very variable. So you're getting the call from the quality director saying, why in the world are our readmission rates 27% this month? And we're like, it's okay, but let's look at it in a 6-month time period, not just 1 month. And so when we went in to look at that, it was, what's driving this? We started with a 10-bundle initiative, and through the analytics, digging through things, we found that actually seeing a patient in the hospital with a heart failure provider was going to drive down these readmission rates. So we really focused on that after looking at the data to see what actually made the impact. So employee engagement. When we talked about employee engagement, when we aligned physicians with the employees, our engagement went up significantly. Who would have guessed? But the other thing that happened here was, if you look in our procedural and inpatient units, the places we've had the most impact, so the door to balloon times, or that slide he showed of red to green, those are the places that we've had the biggest quality impacts to, is having those employees on board with what we're doing.
And sometimes Tacoma is kind of a blue collar city, and we're right next to Seattle. If you want to recruit somebody to the Pacific Northwest, the first thing anybody's going to think about is Seattle, I think. But we can show them what we've done, I think, and we can show them, what kind of quality we give, and the partners they're working with. We're getting our physicians from really good places. So we've doubled, basically. We've gone up to about 80 providers now. Half of those are APPs and half physicians.
So as we go back to the board level, so why is analytics so important? Why is what we're doing with aligning doctors so important? We're able to show them we've increased revenues by $48 million in just 1 year. We've been able to shift market share in 2 years by 3 percentage points, which I don't know if you guys know a lot about market share shifting, but that's a significant shift in 2 years. We grew cath lab volumes by 11% and OR volumes by 19%, which right there, that's the cash cow that keeps the rest of the hospital system going, as cath labs and ORs. So the analytics need to help drive this work was what got us to that point. It wasn't just getting doctors on board with us, but how do we show them data? We know that doctors are driven by data, so giving that to them. So key lessons that we've learned is we must be able to quickly obtain real-time data. We can't be the thinker just thinking about it. We got to actually execute on it and execute on it fast.
And we also have to be satisfied with 80%. If you wait for 100%, you're never going to get there. So, we figured 80% is a pretty good level, and if we can do it 80%, check and adjust, we'll go from there. The aligned provider incentives were very powerful to drive this and to get people working together and get alignment in all of our people.
The DYAD relationship is one of the things that we strongly encourage and enforce and really cultivate within our culture. Is you got to have a physician at the table if an administrator is trying to make a decision. And we're almost to the point where we have to remind the physicians they need an administrator at the table when we're making decisions. And then we got to get comfortable with failing. You're not going to get any closer to success if you don't have some failures. And so we encourage failures. We actually like people to go in and break things for us so that we can actually succeed at fixing it.
Sorry, John, we're 8 seconds over.
They were trying. Let's give Holly and Dr. Ward a big round of applause. All right, so we do have some questions. So in order that they've come in and were top voted, it looks like you've done great things by analyzing the numbers. Do you ever get to the point where you plateau when using numbers and analytics and you've had to go by gut?
And have to go what?
By your gut?
We did a little bit in the readmission work. So as you see, we've kind of plateaued under that 20%. And so we're kind of at this point of, well, do we do something differently, or do we just be okay with the fact that we're not getting penalized for this and doing that work? So yes and no.
All right. Any thoughts from you, Dr. Ward?
No, pretty much the same. I think we like to use our data as much as possible, but sometimes we just have to look at it. You can use data so much, but if you have a homeless drug abuser, it's going to be hard to get them in. And you can pick that up with the data too. Like I said, we have data on that, but it's difficult to treat. Even what Ms. Milgram was saying the other day at the keynote address. It's finding this problem is one thing, but then what do you do about it sometimes? So it's a tough one.
All right. Is physician-level performance masked or unblinded, and how has it been effective in changing behavior?
Yeah, well, I told you it was unmasked in the cath lab. That's a specific place, but also they know, they know what team they're on. They know with that scale that Holly showed, the metric scale. They all know where they are. They know, that's not by name necessarily, but they each get an individual scorecard every month of the scorecard that she showed. Every one of them knows where they are. Now, some of those things are picked up yearly and things like that, so you won't necessarily know. So we haven't gone to the point of putting those out transparently yet. What else do we put out transparently?
Everything's transparent. So if they go into their Click View applications, they can click on anybody's name. So, if I don't like Dr. Ward and I need to show to administration I don't like him, I could go in and find every single bad thing he's doing. Or I could go in and say, wow, that guy's doing so much better at this than me. What is he doing? How is he practicing different than me? So it's all there, and that's why we were so intent on we have to build the dashboards so a doctor can go in and click their name. They don't care how the institute's doing. They care how they're doing. And so they need to be able to click their name and be able to see how they're doing without too much knowledge.
Some of that's gone through like the cardiovascular surgeons, for instance, CT surgeons. They've used that themselves too, to show of the 5 of them, this is where you are, and for all these different parameters and metrics, and this is where, so yeah, it is more transparent.
All right. If you were going to recommend expansion of your model to other service lines, what advice would you give them?
Man.
No, so we just translated it into a neuro service line. And I think the biggest thing is you have to have providers that actually want governance. So you have to have the providers that want to be able to run their business and they don't want to be employed by a health system. And that right there has been a biggest learning for us is if you don't have docs that truly want to do this, then giving somebody the choice to make is not going to get us
It's leadership,
very far.
culture, and governance, yeah. If they're in it for the money, if they say, how can we get more money out of this or something, you'll fail. Quality, you know, the money follows the quality. If you have a relentless, focused pursuit on quality, everything else is going to follow. But if you don't have the leadership, the culture, and the governance, it won't.
But with that, it's a model that can translate if you have doctors that really want it.
What areas do you plan on working on next, given that the gains you've made integrating analytics into your decision-making process?
So right now we're working on looking at the entire continuum. So as you saw, a lot of our metrics were very hospital specific. We've kind of gone a little bit into the ambulatory, but we really want to look at how do we actually impact the entire care continuum. As you know, bundles are coming and cardiology is one of the ones that's most impacted by some of those bundles early on. And so how do we really impact what we're doing with those?
And we have a specific one too. We call it the Millennium Falcon. But it's a hospital. It's a change in how it's a team-based approach to hospital practice, which uses a specified nurse, it uses hospitalists, it uses interventional cardiologists that are focused on getting the studies read on a timely basis and being available for virtual. So we're looking at how do we do that different and what metrics are we going to follow, what ones are going to be the most impactful on how we move the patient along to where they need to go. If that's home or if it's into the cath lab or if it's, whatever, how do we get them there? It's going to be better for them. They'd like to spend less time in the hospital too. So we'd like to move along, decrease their length of stay, decrease our total cost, and improve patient, physician, and staff satisfaction.
And translating our current work into other domains is one of the things we're working with right now of the analytics piece of we're able to put patients on the right clinical pathways in cardiology, but we've ventured out into how do we actually do that with the oncologists to do lung cancer screening and then get them referred in for the thoracic workup. And so that's been, it's a big learning because you're going from physicians that are very aligned with the work we're doing to physicians in an employment model that aren't as aligned. So getting the buy-in and the champions in that regard.
Great. Can you speak to the challenges you had to work through to get access to cost data and integrate it with your clinical data?
Might take all day. Costing data was, as I'm sure you've heard some chuckles, is a hard thing. It's, I'm not sure if it's just a culturally within our health system hard or it's actually hard to integrate a costing software into analytics. And so once we were able to bridge the cultural difference of giving physicians costing data, we were able to start to build that platform between our Axiom database and the EDW. Once that was done, there was a lot of cleanup that we had to do in regards to the attending provider, the practicing provider, the procedure, what CPTs are going to roll up to what DRGs. So there was a lot of mapping that then had to happen after we just got costing data because it doesn't do us any good to know, a CT scan costs this much and a chest x-ray costs this much. It does us more good to be able to say, Dr. Smith, your entire procedure for a cabbage costs this much because you ordered this many CTs and this many labs, and Dr. Jones, yours costs this much. So it was a significant amount of mapping, and I'm not gonna lie, we're still working a little bit on that in our cath lab. Our OR was easy to do, but the cath lab's a little bit more difficult because you'll have one doctor start a case and another doctor come in and finish the case. So who do you attribute what to? And Then there are outpatient procedures, and we've set ourselves up based off of DRGs. And so being able to predict where these outpatient procedures should land in regards to a center of excellence has been another thing.
Pulse has been a little disruptive to the system, and so we heard only a few times maybe that that's not the way we do it, or it's different than we do it, and we had to fight through that. And one of the ways you fight through that, one of the ways you get through that is succeed. And if you can show success, then you get people to start buy in, and it's important to get people from the top to start buying in, because then they tell the people down below them that I want it done this way. So, I mean, we have gone that route a little bit too.
And I think that is an important thing. So finding something that you're going to be able to be successful at, so that you can keep pointing back to. So that for us, it was our cabbage procedures decreased by $5,000 per case. And so we're able to continue to point back to that and say, hey, if you gave our cardiologists the same data that we gave the CT surgeons, we may be able to see even better cost savings than we have now. And so that bucketing it into where can we be successful first, rather than let's build the entire platform all at once.
Great. So we have about 5 minutes left, so probably time for one or two more questions. What readiness assessment did you use when developing your spider chart?
We, Health Catalyst actually came in and did it for us. So I think there's a write-up about it like 3 years ago, isn't there? Yeah. So yeah, it's out there on their Catalyst website, I'm sure. I don't think I'm supposed to promote Catalyst, but they did it for us, and they did a great job.
Yeah, that was when they came in and looked at those 37, took 37 people from physicians, from administrators, from staff, everybody, and put it down and came up with those, what opportunities do we have? They told us what strengths we had, but they also told us what opportunities we had and what we really need to be looking at.
And I would highly encourage it. It's actually something that we continue to go back to of, hey, they told us that. Actually, our chief nurse exec says this a lot because she's the touchy-feely on our team of, they told us we don't celebrate enough. Look, they told us that, so we need to do that. So it is a good thing to have, because it does, help make your case.
Yeah, and preparing for this talk, I looked back at that quite a few times. In fact, I have it in my suitcase right now, the assessment that they did. And I was telling Holly last night, I said, man, they pretty much hit it right on the nose.
What activities are you doing to engage and educate patients?
It's funny you bring that up, because we just had an executive meeting right before we got on our plane to come here we've done a really good job of building value for our physicians, building value for our employees, but the next step in our journey is how do we really build that value for our patients? Obviously, the clinical quality outcomes are coming, and the CG caps have come up, but we really want them to feel like this is the place, and I feel so valued when I'm there. So great question, and maybe in 3 years we can come back and tell you, but right now, don't got anything.
You can come back and tell them.
All right, okay. How do you determine how many physicians you need in your organization?
We have huge access problems. We're like our third next available is like 3 months out. And that's with all the growth we've had. And we've had some negative growth as well, because they didn't fit the culture. And so we've tried to do that quickly if possible, but I think how many physicians we had is when the physicians have to start worrying about their clinical levels not full or something. We really are overloaded with patients right now. And so I think that, and rapid growth sometimes is really difficult, and we've found that out before. But we kind of have a process of growth. We're looking at the areas that we need to grow, working with the system on space is a huge issue now in the system, because now, so if I bring in another EP guy, where's he going to get his cath lab space and things? So it's got to be a collaborative, combined approach from administration to space to IS&T to everybody that works within the system. But as far as how much we'll need to grow, that's not a question we've had to answer, because we just try to keep growing to get our access issues cured.
Well, we do use a database, so we use SG2 to kind of do the provider-physician supply and demand. So it kind of gives us a benchmark of where they think we should be. But like you said, that's one of those gut feelings of, God, a patient that just had a heart attack shouldn't wait.
I mean, SG2.
4 months to see us.
Looking at SG2 6 months ago, they said we were 36 cardiologists short in the Pierce, South King County area, which is our main area. So, yeah, it's not something we have to put a lot of time and effort into figuring out, I don't think, right now.
All right, one last question. Did you send your docs to the AP training program at Health Catalyst?
We didn't send them to the AP program. Needham and I sat through one of the sessions, but what we have done is we have used Health Catalyst to help us find, like I said, we use all physicians when we do our DYAD training. We bring in providers, and we've done a lot of partnering with Health Catalyst to find us people that do very well at that. So we use a lot of the concepts that they teach in that course, because it's the course we took, and we kind of are growing those doctors. But we also use them a lot to, here's a great person that could talk on that for you.
Yeah, and we try to focus, what we're going to talk about too. Like, and one of them was accountability, for instance, and so we had a whole thing on accountability, and things. So, we've gotten a lot of help from Health Catalyst getting the right people in.
Some of it is we don't focus on, here's the whole enchilada at one time. Here's your master's degree in how to become lean and awesome. But what is the one thing we're struggling on right now? Because then they're actually able to focus on something rather than, well, you gave me this, and you gave me that, and you gave me that, and I don't know how to execute on it. So we're very deliberate in simplifying.
All right, well, we are out of time. Please, again, help me thank Holly Burke and Dr. Needham Ward.